Today, we'll be discussing about what we call as scoliosis. As we all know, scoliosis is a complex deformity of the spine, and a clear insight about the basics of scoliosis is very important to determine the appropriate treatment modalities for these patients. So, scoliosis is defined as a three-dimensional rotational deformity of the spine. So, as we all know, the spine is a straight structure in the coronal view. And when there is a bend in the straight structure in the coronal view, that is the AP view, it is termed as scoliosis. It is not a two-dimensional deformity in the sense the spine or the vertebra rotates in its axis, thereby resulting in a three-dimensional rotational deformity. And scientifically, it is defined as a lateral curvature greater than 10 degrees in the coronal plane, that is in the AP view, as determined by measuring the Cobb's angle, and we will be discussing about all these in the future slides. So grossly, scoliosis can be divided into these types. The commonest type of scoliosis is the compensatory type of scoliosis. Compensatory means whenever there is a limb length discrepancy or whenever there is a pathology in the intervertebral disc compressing the nerve root, the spine will take up a curve, and that is called as compensatory scoliosis because it compensates for some pathology in the body. The next type is the congenital type of scoliosis. As we all know, the term congenital means something which is present from birth, and it again can be divided into three types, which could be failure of formation, or it could be due to failure of segmentation, or it could be due to a combined failure of formation and segmentation. The next type is the idiopathic type of scoliosis, which is the commonest type of scoliosis. And this idiopathic scoliosis can again be divided into three types as infantile, if the scoliosis presentation is between 0 to 3 years of age, or it could be juvenile when it is between 3 years and 10 years of age, or it could be adolescent if it is greater than 10 years of age. And this adolescent scoliosis is the commonest type of scoliosis which we will come across in our day-to-day clinical practice. The next type of scoliosis is the neuromuscular scoliosis. And this neuromuscular scoliosis could be either because of neuropathic causes or it could be due to myopathic causes. And the final type of scoliosis is syndromic scoliosis, when it is associated with various syndromes like Ehlers-Danlos syndrome or Marfan syndrome, etc. So today in this session, we'll be discussing mostly about the idiopathic type of scoliosis, especially adolescent idiopathic type of scoliosis, because that is the commonest type of scoliosis which we will encounter. Again, scoliosis now been classified into early onset scoliosis, EOS, or late onset scoliosis. Early onset scoliosis is when it presents less than 5 years of age, and late onset scoliosis when it presents greater than 5 years of age. Now, what is the basis of this classification? Because the alveolar, the lung alveoli achieves its maturity, 80% of its maturity by 5 years of age, and almost the alveoli reaches its peak maturity by 8 years of age. So, as I said, scoliosis is a three-dimensional rotational deformity of the spine, and it affects not only the spine. Because of the deformity, it reduces the chest wall or the thoracic cavity's volume, and the space available for the lung reduces, resulting in a restrictive kind of lung pathology or a pulmonary pathology. And these children usually will present with breathlessness. And because the alveolar maturity is predominant in the less than 5 years old group, these patients will have severe pulmonary issues, and that is the reason why they have classified like this. Now, when we come across a child with scoliosis, history taking is very, very important. As I said, adolescent idiopathic scoliosis is the commonest type of scoliosis, and it is very common in the girls. So the onset is very, very important because usually this adolescent idiopathic scoliosis, they present after 10 years of age, and they tend to be neglected because the girls usually they don't expose their body, and they will come to know, or the parents will come to know about the deformity when there is a gross curve in the spine because of shoulder imbalance, and it will result in gross imbalance of the shoulder. Then comes the duration of scoliosis. How long it is present, whether it is for many months or many years, that is very, very important. Then is the progression of the curve. Whether they had noticed a small curve and it has progressed significantly over the past few years, or it is very slow progression because the progression of curve determines the appropriate treatment modality. The most important history is the antenatal, natal and postnatal history, especially when we are dealing with congenital type of scoliosis, to rule out other causes or the associated syndromes in these children. The next vital history is the menarche. As I said, AIS is very common in girls. And during menarche, the girls attain peak height or peak growth velocity. And during this period, there will be sudden progression or exacerbation or exaggeration of these curves, and the deformity will progress very fast. So the age at menarche is very, very important. To give a clinical example, suppose a 12-year-old girl presents to us, and if they give a history that the child has not attained menarche yet, then we have to be very, very careful because there will be a sudden worsening of curve during this period. Whereas if you are dealing with a 14-year-old girl with a curve, and if they give history that she has attained menarche 2 years back, then the risk of progression of the curve is definitely less compared to the child which we discussed earlier. The next one is pain. Most of the children, they will be brought by their parents for cosmetic deformity. Pain is not a feature of scoliosis, especially adolescent idiopathic scoliosis. When we encounter pain as a symptom, then it is a red flag and it has to be investigated in detail. The last history is neurological involvement, whether the child has any weakness or numbness of the lower limbs, because even in adolescent idiopathic scoliosis, about 18 to 20% of the children will be having spinal dystrophism or like myelomeningocele or diastematomyelia, etc., or tethered cord syndrome, which can result in neurological involvement. So when we go on to the examination part, the first and foremost thing which we have to see is we have to look for the neurocutaneous markers. So whenever there is a neurocutaneous marker, when it is present, it indicates that there could be a presence of spinal dystrophism like diastematomyelia, myelocele, myelomeningocele, something like that, or tethered cord syndrome. And these children has to be evaluated immediately with MRI scan to rule out any spinal dystrophism. Now coming to the examination of scoliosis child per se. So as I said, examination of spine should always be done with the examiner standing behind the patient. So the first and foremost thing which we have to look for is whether the head is centered over the pelvis or not. How do we know that? On inspection, we have to look whether this head is just above the pelvis or not. And in palpation, you can just drop a plumb line from the C7 spinous process and you can see whether the head is centered over the pelvis or not. And the plumb line should fall between the gluteal folds.